So hello everyone, I hope I'm audible and visible to all of you. Can you just give me a quick thumbs up if my audio video is fine? All my dear students, can I just get a quick thumbs up if my audio video is fine? Just a second, let me just check. Yes, very nice. So welcome all of you in this session of case-based discussion in dermatology with me. I'm Dr. Chesta, your NEET PG educator on the best online platform, that is Unacademy. Now we are scheduling a mock test on 26th of February, that is 9 a.m. I requesting each and every one of you to please be a part of this mock test. It's a free test. You need a code, that is Chesta10, to get yourself enrolled. Please do give this test, as it is free test. You will get a all India rank, which will help you adjust your preparation accordingly. Now we have few offers which is only till 9th of February. So I request everyone to give just have a or just take this subscription of 36 month or 3 years to get 6 month free, 2 years for 4 month free, and 12 a month for 2 month free. There are two type of subscription. One is Plus, which give you an access to Unacademy live classes, and Iconic give you an access to both Unacademy and Prepladder. Now I congratulate to all the dear students who have cleared their FMG exam. This is the list of the test which is free test for this month. I request all of you to please be a part here as well. We have special classes which are the free live classes. For those can be attended very easily. You just need to download the app. Every day at 3 p.m. I take free live classes on Unacademy app. So you just need to go to the Unacademy app, go to my profile, and you can just have a look. We have a highly effective question bank of around 25,000 plus questions, and we have a feature which is known as raise a hand. So you can just raise your hand and ask your doubt. Now we have a NEET PG high yield MCQ batch, and we have a focus FMG batch scheduled for 9th. We have a image based question session for 9th and an ultra fast rapid revision batch for 9th. So requesting all of you to please be a part of it. An integrated next batch is also starting for 2023 exam. Now we have announcement that the prices of Iconic have dropped if you take it for 1 year. Iconic means the access to both Unacademy and Prepladder. If you take it for 1 year, initially the prices was 50 to 500, but now it becomes 43 to 100. And for this also you need a code, and that is Chesta10. So kindly use this code and get your subscription today. Now for the Plus, I would highly recommend a 2-month subscription. Again, using the code Chesta10 will give you an access to Unacademy for 2 months with the price of 6750. Now starting with the image based question, I request all of you to please answer these questions. What will be the answer to this question? Anyone? 18-year-old male with multiple painful pustules, weeping ulcers with hemorrhagic crust, which are presented on cheek, forehead, along with development of cyst. This was accompanied by fever, arthralgia, lethargy, and the patient was admitted for supervision. Complementary investigations reveal leukocytosis with neutrophilia, and there is raised ESR. You have elevated ESR which could be seen. Elevated ESR which could be seen. The radiograph imaging reveals no bone involvement, and there is a history of oral isotretinoin intake 14 days prior to the onset. Now both these history of associated inflammation and associated history of intake of isotretinoin give you a diagnosis of acne fulminans. Please remember, we have two type of severe form of acne. One is acne conglobata and one is acne fulminans. So what is acne conglobata and fulminans, or how does they differ? Please remember, in acne conglobata you have nodulocystic lesions. More commonly you have nodulocystic lesions, while in acne fulminans you have, in acne fulminans you have again nodulocystic acne, which is associated with constitutional symptom, which includes fever, arthralgia, etc. Now there is one more very important feature of this particular condition, and what is that feature? In acne conglobata, the treatment of choice would be oral isotretinoin, that is oral retinoid. But isotretinoin is contraindicated in acne fulminans because it can precipitate the development of acne. So what can be done? Please remember here the treatment of choice becomes steroid, oral steroid. So that is how you can differentiate a patient of acne fulminans from that of acne conglobata. You can differentiate the patient of acne fulminans from that of acne conglobata. Is this clear? So an 18-year-old male with multiple painful pustules and weeping ulcers, hemorrhagic crusting over the few lesions of cheek, forehead, along with development of cyst, the correct answer becomes option number 3. Next question is on your screen. How to calculate the dose of isotretinoin? Please remember the total cumulative dose we need to calculate, because if you exceed the cumulative dose, it can cause a lot of side effects or severe side effects. So that is why what you do, you just calculate the dose 120 to 150 mg per kg. That is the maximum cumulative dose for isotretinoin. Maximum cumulative dose. You should not extend the isotretinoin beyond this particular dose. Otherwise, pancake, if you have to give it for any indication, you give it according to the body weight of the patient. We usually try giving it with a lesser dose of 10 mg per day or 20 mg per day, because it causes a lot of dryness on the skin or lips. So we don't want to precipitate that particular condition. Very nice, pancake, Meena, Farhad, Staffy, Dr. JP. A 40-year-old woman employed since 2 months for brushing the dye off the clothes in a small cottage industry employing 3 persons, presented with complaints of reddish itchy eruptions that appeared sequentially over the face and neck within 3 weeks. Examination revealed multiple comedones and a few inflammatory papules involving the forehead, peripheral area of face, specifically the mandibular area, and a few lesions were also present on the chest, axilla and thigh. What could be your diagnosis? The correct answer of this question is definitely option number 1, that is occupational acne. Now, how to differentiate occupational acne from that of the acne vulgaris? That is a very important question. How to differentiate occupational acne from acne vulgaris, because you get a lot of confusion. Now, occupational acne, please remember, it is monomorphic. Please remember, it is monomorphic, while acne vulgaris is polymorphic. What do you mean by monomorphic or polymorphic? Now, monomorphic means you have only one type of lesion. It can be all comedones, or it can be all papules or all pustules. But in acne vulgaris, at one point of time, you will see all the type of lesions like comedones. You can have papules. So you can have comedones, you can have papules, you can have pustules, and you can have nodules. So at one point of time, you can have any type of lesion in the patient of acne vulgaris. So that is a very important feature when you compare occupational acne with that of acne vulgaris. And that is what is given here. If you look at the image, all comedones are seen here. All comedones. There are no papules, pustules, all comedones. So very, very classical. Please remember, this type of acne is sometimes also known as chloracne, because it occurs secondary to hydrogenated carbons of chlorine. Okay. Okay. So let's go to the next question. What is the correct answer? A 40-year-old male presented with chief complaints of ulcer in the mouth and difficulty in swallowing solid food liquids since 20 days. History revealed that patient first noticed dysphagia for solid food, which is progressively increasing in its severity. At the time of presentation, the patient had dysphagia of liquid as well, and patient had noticed ulcers of the mouth which bleeds on brushing, and increasing salivation was also noted. Patient did not report any skin lesions or involvement of other mucosal site, and on doing the microscopy from the lesions, large round cells with hyperchromic nucleus is seen. What could be your diagnosis? Large round cell with hyperchromic nucleus. Can anybody tell me what is this? Large round cell with hyperchromic nucleus. There is mucosal lesion which is seen. What could be the best possible answer? Steffi, Farhad, Pancake, Marzina. No, the answer is option number 3. It is not leukoplakia. What are these large round cells with hyperchromic nucleus? The large round cells with hyperchromic nucleus are acantholytic cells. And how to describe an acantholytic cell? They are large round keratinocyte. They are large round keratinocytes. 1. What is the second very important point? They have hyperchromic nucleus. Hyperchromic nucleus. And what is the third point? They have a perinuclear halo. They have a perinuclear halo. All these points, they favor the diagnosis of option number 3, that is pemphigus. They all favors the diagnosis of option number 3. So a 40-year-old male with chief complaints of ulcer, and on doing the smear you could see that it is a round hyperchromic nucleus. The answer is pemphigus group. Any confusion? Meena, Steffi, Pancake, Farhad? The next question, case-based discussion. A homosexual man was admitted in the emergency department with pain on defecation. The general condition was good, and on examination he had clustered ulcer extending into the anal canal. The likely diagnosis is cytomegalovirus, gonorrhea, herpes genitalis, or HIV. What will be the likely diagnosis in these individuals? What will be the likely diagnosis in these individuals? Ma'am, where are Zang cells seen? So please remember, Zang cells are the features of intraepidermal acantholytic disorder. It could be seen in the patients, those who have pemphigus vulgaris, pemphigus foliaceus also. But in pemphigus foliaceus, the oral mucosal involvement is not seen. So that is one of the difference. The answer to this question is absolutely correct. You all are that it is herpes genitalis. You see multiple grouped lesions around the perianal skin. So that is a case of herpes genitalis. A woman presenting with a heavy foul smelling discharge with sharply demarcated ulcers without induration on the perineum and labia majora. Inguinal lymphadenopathy is also present. What is the most probable diagnosis? What will be the most probable diagnosis here? Woman with heavy foul smell discharge with sharply demarcated ulcers without induration on the perineum and labia majora. Anyone can tell me the answer here? Now here the important point is there is presence of ulcer. Important point is you have, yes, you all are right, the presence of the genital ulcers, sharply demarcated ulcers, which is soft. So they are an example of soft canker. Soft canker is a very characteristic feature of chancroid. Now chancroid is secondary to Haemophilus ducreyi. Haemophilus ducreyi. Clear? Next question. A 32-year-old pregnant woman is asymptomatic and has a history of syphilis 7 years back. Her VDRL is negative and TPH is positive. Which statement is correct? Which statement is correct? significant risk of congenital syphilis, CSF examination need to be done for mother, mother has active syphilis, or no management is required. What is the answer for this question? Anyone? 32-year-old pregnant woman is asymptomatic and a history of syphilis 7 years back. Now there is a past history of syphilis. Currently the VDRL is negative but TPH is positive. So how will you manage this patient? The correct answer of this question is option number 4. Please remember, once a patient becomes positive for syphilis, the treponemial test remains positive for a very longer duration. Treponemial test includes TPHA, TPI, FTA, ABS. All these tests remain positive for a very longer duration, whether the patient is an active case or it is a treated healed case. But if VDRL is positive, then only you need to consider the treatment. So the best answer is no management required. We even do not require the CSF examination. So please don't get confused. Why will you do a CSF examination in a patient who is not active? If he would be active, there should be VDRL that is positive, but that is not given in this question. The VDRL and TPHA, both of them are negative. Very nice. Next question is on your computer screen. A 27-year-old sexually active wife of a long-active truck driver presented with copious vaginal discharge of 2-day duration. So can you see, this is a colposcopic image and you can see a lot of white thick discharge in the vagina of that female. Which of the following should be given in this patient? Which of the following should be given in this patient? Which of the following should be given in this patient? Anyone? Very nice, Staffy. CSF examination is required when we are suspecting it to be a case of neurosyphilis. We do usually CSF examination. We do VDRL of the CSF in a patient of neurosyphilis. The answer to this question is option number 3. Now, vaginal discharge, we usually treat it with kit number 2. Kit number 2 includes secnidazole, which belongs to the same group as metronidazole, plus we give fluconazole. Secnidazole will take care of bacterial vaginosis plus trichomoniasis, and fluconazole will treat what? Fluconazole will treat candidiasis. So these are the 3 main causes of vaginal discharge in a sexually active female, and that is why you give kit number 2 to take care of these conditions. Okay? And the content is metro plus fluconazole. The content is metro plus fluconazole. Next question is here on your screen, and I would request all of you that at 5 p.m. that is after 4 minutes, we will be starting with our session, that is the open house session. Today the topic is topper's tip. So I request all of you to please be live, please be live on this session, which is a free session. You can download the Unacademy learning app and you can attend this open house session. Azithromycin can be given in trichomonas. We usually prefer a drug which has more of anaerobic control. So we tend to give metronidazole, which is preferred better for trichomonas infection. The answer to this question is eczema herpeticum, which is also known as Kaposi varioliform eruption. Now what happens in a patient of atopic dermatitis, the herpes lesion, it tend to have a widespread nature. Usually we see herpes very localized at the mucocutaneous junction. But in the patients of atopic dermatitis, because of defective barrier, they develop generalized herpes simplex infection, and this is known as eczema herpeticum. This is known as eczema herpeticum. With this, we are done with today's session. I hope you have enjoyed. I request all of you to please subscribe the YouTube channel, that is Let's Crack NEET PG, which is a free YouTube channel. Also follow us on the Telegram group with the same name. Use the code CHESTA10 to get Unacademy subscription, and please give a thumbs up or press the bell icon for all the notification. I request all of you to please join the open house session right now. At 5 p.m. you just need to download the Unacademy learning app, and please listen to me. Today's topic is toppers tip to crack the exam. So thank you all of you, and we will be meeting just in 1 minute on your Android phone. It is only accessible to the Android phone. Just download the Unacademy learning app and be with me for